Very warm welcome to this DENT Echo session. It's the first of the new year for us. And we're very happy to see everybody here. For those of you who might be new to Echo, this is a model that builds virtual communities of practice and learning. Today's session is going to begin with a didactic presentation with case-based learning that's integrated into the session, and also includes a group discussion that's going to foster deep knowledge and build individual capacity. We are very honored to have you all here, and we appreciate seeing your lovely faces. So if you are able, please do join with your video connection. Before we carry on, I'm going to ask UT Echo IT to share some guidance about your connections.
Hello, everyone. Thank you for joining. Please stay muted unless you're speaking. You can mute or unmute using *6 on your phone if you've called in, or the microphone icon on the bottom left of your screen if you've joined on a computer. You can also communicate with the chat feature. If you have any issues, please chat UT IT. Thank you.
Thank you so much, Go IT. Please do enter your name and affiliation and your email into the chat. It really helps us to keep connected as a community. We're going to start with some introductions right now. And first, I would like to ask Dr. Chala. Dr. Chala, we will unmute.
First of all, welcome to everyone. Thank you all for taking the time out to meet with us today. And I serve as the Associate Dean for Strategic Initiatives and Advanced Education, and the PI for this grant that supports our DENT Echo. And with that, I want to give you all a warm welcome.
Thank you so much, Dr. Chala. Dr. Aguilar.
Hi, good afternoon, everyone. I'm Dr. Rosalie Aguilar, and I am one of the co-directors for DENT Echo. We are excited to have you here today and looking forward to a wonderful conversation and a wonderful presentation.
Thank you, Dr. Aguilar. Ms. De La Torre.
Hi, everybody. Welcome. Thank you for being here. I'm Magda De La Torre, also one of the co-directors for DENT Echoes.
Thank you, Magda. Thank you so much for being here. And last but not least, Professor Carrillo.
Hello and welcome, everybody. I'm excited to provide this presentation, and I'm going to try and get my screen going up and get started.
Absolutely. And just before you do, we just have a few announcements regarding continuing credits. So if you have signed up to receive continuing credits for your registration, you will receive an email with instructions and then also with the post-session evaluation. It'll guide you how to attain your credits. Now, Echo is an all teach, all learn environment. And so we really encourage participation today to try and encourage each other and learn as much as we can. Our session today will include a didactic presentation from Professor Carrillo on American Academy of Periodontics, the AAP 2018 classification made easier. And this is going to be an extremely exciting session. You have a couple of handouts that I believe were sent to you in your email. Please do keep those with you, as we will be using them and referring to them. And that's really going to encourage and enable us to have a really fruitful discussion today. In the spirit of all teach, all learn, we really encourage you to use the chat box to raise any questions or comments. We will be monitoring that as well. Professor Carrillo, whenever you are ready, just go ahead, share your slides, and thank you.
All right. Welcome, everybody, and I hope you're all having a wonderful Thursday so far and staying warm and safe. And I appreciate you sharing your lunchtime with me. I would like to say a little about myself. I'm a full-time assistant professor at UT Health San Antonio in the Division of Dental Hygiene in the Department of Periodontics. I have the pleasure of teaching periodontics and advanced periodontics to the junior and senior dental hygiene students, to include the bachelor degree completion students. Before we get started, I just want to, I just would like to say that the purpose of this, I just wanted to have an idea of my audience. I would like to ask, what field of dentistry do you work at? Is it a school environment, community, private practice, or are you in another medical profession or a student? You can put your response in the chat box if you don't mind. gives me an idea of my audience and understanding where I'm going to, the information I'm going to present. Okay, I thank you for giving me your input on that. Public health, hygienist, program coordinator, health program. Welcome, everybody. I'm happy that you're here. And the purpose, I'm going to get started. The purpose of this DENT ECHO presentation is to assist you with a better understanding of the 2018 classification system with using the criteria and the staging and grading that will help you with determining your periodontal classification for your patients. What caught my attention and why I like this 2018 classification, because it presents periodontitis in much the same way other diseases are categorized, such as staging for cancer. Staging is an approach used for many years in oncology. And for example, when you talk about staging for a patient with cancer, if they hear stage 4, they understand that it's more serious than stage 1 cancer. So the methodology is used the same way for periodontitis. This is an example of how you might communicate to your patient the current severity and extent of their periodontitis, as well as clinical complexities of managing their case. So today we will review some key steps with staging and grading that will hopefully make using the 2018 classification easier to understand and utilize. So let's get started. And I gotta find my little, where'd my key go to? There it goes. So we're gonna, starting off, we're gonna review our objectives and we're gonna go over the 3 steps of staging and grading a patient. We'll briefly discuss the new terminology of the 2018 AAP classification and apply the concepts and criteria for staging and grading to some clinical cases. So we'll be a little interactive and we'll be utilizing our forms there. So have them close by, and also we'll be doing a little calculation. So if you can have a calculator close by, you'll know when to use it. Okay, I'm going to close this. So the relevance of this classification is it provides a personalized approach to patient care. It helps us as clinicians develop a well-rounded treatment plan and strategy for patient-specific needs and assist clinicians with communicating their clinical findings accurately to their dental care providers and patients. It can help us with providing devising a diagnosis and treatment plan, and collaborating with your dentist on it, and predicting treatment outcomes that will make it easier for your patient to understand what the necessity of them coming in on a regular basis every 3 months, and helping them take ownership of their oral health and systemic issues. I'm trying to find my, I have the pictures, there it is. Okay, I'm gonna move myself out of the way. So first off, I'm trying to get my pictures, I apologize, they're in my way. First off, we'll have a brief review of the differences between the 1999 and 2018 classification of periodontitis. Did you know that it's been over 20 years since we've had a change in the periodontal classification? So I think it's an exciting time for us as clinicians in providing a classification that patients will understand. And by using this stage and grade, I think it will help them have a better understanding, not only them, but the medical profession, our dental community. It will give us a good understanding on this. So this 1999 classification, over the years, clinicians and researchers, this 1999 classification is subdivided into two subgroups. When it was out, we used to have chronic and we used to have aggressive. So this new classification regrouped the two under a single form term called periodontitis. The 1999 classification also used descriptors of slight, moderate, and severe. And the diagnosis could also be divided into several severity levels for different parts of the mouth. For example, when we used to divide it, I remember we still hear it sometimes. They would classify the patient as generalized moderate chronic periodontitis with localized severe chronic periodontitis. But the 2008 AAP classification has changed the dividing of the diagnosis. So the changes of the 2019 AAP classification, it provides a personalized approach to patient care that is essential for effective management. It has a multi-dimensional view of periodontitis, incorporating staging and grading. And the 2018 classification has only one stage and one grade that can be assigned to a patient. It cannot be subdivided into two different severity levels. So once you find that stage, there'll be either stage 1, grade A, periodontitis, and you cannot give them a second one. So you have to identify that. What I really like about this new system too is that it brings in the grading system, which includes our oral systemic link. And it'll provide us a better way as clinicians, a better way to communicate and educate the individual patient on their risk factors that might be contributing to their patient's oral health problems. This is some of the new terminology that has come out of this new 2018 AAP classification. And we all know biological width. And I'm just going to cover a few of these. It's now called supracrestal tissue attachment. It's a lot of a big change here. And the biological width, we all know, is a space on the tooth surface or zone of the soft tissue that occupies the JE and the connective tissue attachment, connective tissue fibers. And it's so when you hear supracrestal tissue attachment, you can abbreviate it, SCATA, but this is the new term. And then also, as I discussed earlier, that chronic and aggressive periodontitis is now, apologize, wrong area, is now under one category, under periodontitis. And how we identify aggressive is under the new extent terminology called molar incisor pattern. And you'll see it underneath when you grab your staging form. If you have it, you'll see it under extent. And this is how we can identify the old terminology of aggressive. So when you identify a patient with this, you're going to call them, you'll identify it by using molar incisor pattern, the MIP, and it's what identifies the aggressive over when you find that in a younger adult. And then the Miller classification is what was most widely used for since 1985 to classify mucogingival conditions and gingival recession. The Miller classification used to use class 1, class 2, class 3, and class 4. And I know it's still being used out in private practice, but the new terminology for the Miller's classification is now called the Carrillo classification, and it uses RT1, RT2, and RT3, which stands for the recession type. And how it helps me remember Cairo is I think of Egypt, Egypt and Cairo is the capital. And I have a fun way of remembering RT1, RT2, RT3, you know where I'm going. I think of Star Wars. I like, and that's how I remember, and so I won't forget that this is the new classification. It kind of guides me and reminds me on how to use it. And I won't go into the definition of each one of them because it'll take a little more time to do that. But if you ever want to talk about it, I'd be happy to. So the definition, before I define a patient of a periodontitis case, I would like to explain that the software we use in the clinic up here in the university is called Axiom. So we use, when we identify loss of attachment, we call it clinical attachment loss. But sometimes out in town, we call it, or it's the same thing as loss of attachment. So if you hear me say CAL or LOA, know that when I'm saying CAL that I'm using the clinical attachment loss, or AKA loss of attachment. So this way we're on the same page. So a periodontitis case is a patient who presents with interdental clinical attachment loss, and it has to be on the mesial and distal, not facial and lingual. And it's detectable at 2 or more non-adjacent teeth. And also the facial and lingual, you can use it if it has clinical attachment loss of 3 millimeters or more with a pocketing greater than 3 millimeters, detectable on 2 or more teeth. But the one we're going to be looking at is the mesial and distal. We're going to be looking at these areas as well. That's what is going to guide us on our on us classifying them. So there's some key points to remember when you're classifying the patient. The observed clinical attachment loss cannot be attributed to non-periodontal causes, such as gingival recession of traumatic origin, dental caries extending to or apical to the CEJ, the presence of cal on the distal of second molars due to malposition extractions of third molars, endolesions draining through marginal gingiva, and the occurrence of vertical root fracture. And I had the last two on my number 30. Had an endolesion, and when they went to measure my pocket, it wasn't due to perio, it was due to the endolesion, which had given me about an 8 millimeter pocket on that area on the mesial. So I know I don't have periodontitis, but this is a great example of that. So here's some images that will help you with that. And so here's gingival recession. Can you see my cursor there? Yes? Around the margins. So this is due to trauma from toothbrush abrasion. You'll see it here. The presence of clinical attachment loss on the distals of the second molars due to malpositioned extraction of third molars. Here's an example of an endolesion draining through the marginal gingiva, a vertical root fracture. I had both of those, and dental caries extending to or apical to the CEJ. So these cannot be used to identify as perio. These are some of the exceptions that we wouldn't use. So any questions so far on the material I've just covered as far as the new terminology? No? Okay. If so, you can type it in the chat box. If not, I'm going to move forward. And we'll go on to identifying the 3 categories of periodontal health. So you have periodontal health on an intact periodontium. You'll have periodontal health on a reduced periodontium in a non-periodontitis patient, and periodontal health on a reduced periodontium in a past perio or periodontitis patient. So this is an image of periodontal health on an intact periodontium. This means this patient will present with probe depths less than 3 millimeters. You're not going to have no bleeding on probing or clinical attachment loss or alveolar bone loss, and no signs of inflammation. So this is what we all like, or would like our oral health to be. So now we have gingival health on a reduced periodontium in a non-periodontitis patient. So this patient presents with no bleeding on probing or less than 10%. They have no interproximal bone loss. And you want to always use the radiograph to confirm this. And most of this is probably due to trauma. And you would, and I have to investigate sometimes. Whenever I see this is pretty healthy. And you'd want to ask them, have you ever had, if you have someone that's older and has a little bit of loss of attachment, sometimes you want to ask them, have you ever had any type of treatment called non-surgical periodontal therapy, which out in private practice, we call it scaling and root planing. And I'll go into that in a bit. But when we ask them that and they've never had a history, then we know, and they have these clinical signs of the no bleeding on probing, but yet they love their teeth clean, but they're real aggressive brusher, or maybe it's due to ortho. You have a variety of things that could be causing this. So this is what we have to look at, and that's part of our job to investigate this. And for this type of patient, you would want to treat them with a D110 prophylaxis. And for the healthy but reduced periodontium, in a past perio patient, this is a successfully treated stable perio patient. Their probe depths are less than 3 millimeters. They control all systemic factors. They have complete resolution or minimal signs of their inflammation. And in other words, they've learned they've learned everything that has gone on and don't want to go back to that, what they've had. So we always need to remember that when a patient is a periodontitis patient requires lifelong supportive care to prevent reoccurrence of disease, and they will remain a D4910 periodontal maintenance patient for life, even following successful periodontal therapy. But you can document on this patient, you can document that he's healthy but reduced periodontium in a past periodontitis patient. But on this one, you can give him a stage and a grade, but on the past, this one here, you would document his loss of attachment, their loss of attachment in their perio chart, but you do not provide a stage and a grade on this non-periodontitis patient. But on this one, you could provide a stage and a grade, but you still can, if they're really healthy, you can also put healthy but reduced periodontium in a past perio patient, but you would still do the 4910 on them. Is that understand it? Everybody understand that? Yes. Yeah. So here I have an example. This is some interactive. We have a case study, this little one here. He's a 40-year-old male. He has his medical history. He just has seasonal allergies, takes Zyrtex for it, no social habits reported, and his dental history, he's a new patient, so we don't know. So during the assessment of the patient, you note clinical signs of periodontal health and no bleeding and probing on a stable periodontium with pre-existing loss of connective tissue and alveolar bone. The patient reports a past history of NSPT. And so how would you classify this patient using the 2018 AAP classification? And what type of treatment plan would you recommend? Would you provide them? In the chat box, you can put this, your answer, and also give me the code, the treatment code that you would consider for this patient. So the clue is you would look, the most important clue would be the past history of NSPT. I can't see anybody in the chat box responding. No?
We've got some responses in the chat. See a lot of C's and D's
Okay,
along with 4910.
yes. So that's good, yes. And you're correct. It is a healthy but reduced periodontium on a past perio patient, and the clue again was the past history of NSPT. And I'm going to go into that real quick. The NSPT is the therapy that we provide, and underneath it, scaling and root planing fall as one of the procedures that help us get that patient back to health. And so NSPT is the therapy, and the treatment that we're going to provide underneath that is scaling and root planing. It can be laser, it can be irrigation, it can be arrest, and those are some of the procedures that we'll do to get them back to health under non-surgical periodontal therapy. So if you're wondering where that terminology comes from, that's what it is. And it's a way of us differentiating ourselves from a periodontist and what a dental hygienist does. So I hope that's helps with the explanation on non-surgical periodontal therapy. So the next case study I have, little mini one, there's that 4910, is a case study 2. And he's a 54-year-old male. He reports no systemic issues or risk factors, no history, he states, of NSPT. He has bleeding and probing less than 10%. And this patient is compliant with his 6-month recare dental visits. And his remark is he loves his teeth clean, so he uses a hard toothbrush. So how would you classify this patient and what type of treatment plan code would you recommend? You can put your answer in the chat box. Or if you have any questions. Yes. Good job. I'm trying to figure out my little, it should pop up. There it goes. And yes, a D110, that is correct. So did this part of this material, these 2 case studies help you understand a healthy but reduced non-periodontal periodontitis patient and a healthy reduced past perio patient, and how you would use those 2 new classifications that are under the 2018 AAP classification? I hope it did. So we're going to go on. No questions in the chat box on it? I'm practicing my breathing too here. I like this little cartoon. It says, it's Miss Jones who you scaled this morning. He's talking to the hygienist. She wants to know if she's supposed to feel her heart beating in her gums. That's cute. So we're going to go on now to the 3 steps in staging. And the first step in this one, we're going to cover the staging and grading in detail too, and brief. But the stage 1, I want to go over a little more because this one will help you and guide you in finding your stage and grade as you're doing your assessments. So if you have your staging and grading form available, please have that out, and also a calculator if you have it for when we get to the grading portion. But the step 1, the medical history and patient's assessments are very important steps in identifying clues when finding a stage and grade for your patient. It's like doing a little detective work that will guide you with determining this stage and grade. For instance, when I'm doing their medical history, I'm going to be listening to them, and I'm going to ask them, when we get to diabetes, are you diabetic? And if they say yes, I'm going to ask them right away, okay, do you happen to know your A1C? And if they do know it, that's a blessing, because that'll help us. Because what I'll do is I'll take my grading form that I have laminated or in a sheet, and I'm going to say they're diabetic, and I'm just going to write that down and remember it when I get to grading, because it's going to help me. And if they're a smoker, I'm going to ask them, how many cigarettes do you smoke? Do you happen to know? Do you smoke 10 more, less? And once they tell me, I'm going to remember and write that down, because it's going to help me with my grading as well. So then also the full mouth periodontal, the full mouth readings of the probe readings. These will help you identify a clinical attachment loss. It'll help you identify furcations, mobility. These will help you all with your complexities when you get to staging and finding the correct stage for your patient. So that's what you're going to use for that. And when you get into your radiographs, they're going to help you identify bone loss, and also not mobility, but furcations. That'll help you with that. And so that's going to confirm the furcations that you identified with your probing, and it'll help you come to an accurate staging for this patient. It also identify missing teeth, the radiographs. So it'll help you identify that. And when you see that, that's when you should ask the patient, how did, when you're in there doing their intraoral exam or you're doing their charting, how did you happen to lose this tooth? Was it due to decay, or was it due to periodontitis? And usually I kind of get a clue. If they have a full mouth of restorations, I'm kind of thinking, okay, it's decay. But if they don't, and they have several missing teeth, I want to inquire to make sure that it's not due to decay, or they had it extracted, or root canal, something that went bad. But I want to look, and you kind of do your own investigation to find out what these are. But this stage 1 will really help you with your staging and grading. It will guide you and get you to come out with an accurate stage. So this is the form. So if you can, if you received it and you have it, we'll pull it out and we'll get to use this. And this is, we're going to get into some of the interactive portions of this, and I'll clue you when it's ready. We'll be using the form. So staging relies on the standard dimension of severity and extent of periodontitis, but it adds adds the complexity of managing the individual patient. So staging is based on measurable amounts of destroyed or damaged tissue as a result of periodontitis. It assesses the specific factors that may attribute to the long-term case management of a patient. It has 4 categories that are determined by several variables and range from the least severe stage 1 to most severe stage 4. The criteria used to determine a stage are the severity, and you'll see that on your form. If you have your form in front of you, you'll see the sections, and it'll say severity on there. It'll say complexity, and then you'll see extent and distribution. And each one of these sections we'll cover briefly, but have it in front of you. So as you're using it, you'll learn to understand where we're going at each one of them and identify. And the ones that you're going to see the most complexity in are going to be your stage 3 and 4. So to determine the severity, you're going to look at the clinical attachment loss, which you see on your form. You're going to look at your radiographic bone loss, tooth loss, and you want to remember that there's only going to be 1 stage and 1 grade per patient. And you also want to identify the site of greatest loss, also known as the worst site. So that's something you want to do. So we're going to cover clinical attachment loss, and we all know that it's the probe depth plus recession, which will give you your clinical attachment loss, your CAL. So this is what I'm going to be looking for. Once I get it, I'm going to look on the clinical attachment loss area on my probe chart that I will that will help me identify, because I'm going to go up to stage 1. If you look here on stage 1, it says that they have to have 1 to 2 millimeters. That means that their probe depth and the recession equaled 1 or 2 to 2 millimeters. So this one here, their probe depth plus the recession equaled 4 millimeters of cal. So I'm already circling here that it helps me identify stage 2. And remember that if cal is not available, probe depths and radiographic bone loss should be used at all times to identify your loss of attachment interproximally. And we have a little, the next one is a little interactive slide. And so what I would like you to do is in the chat, I would like you to identify any clinical attachment loss that you see on this probe chart. Is there, go to your staging, to your endodontal severity levels and find the worst area and type in the stage that you think this patient would be. Let me pull up the chat. Okay. Let me, I'm trying to find my pen here. Everybody understanding the clinical attachment loss? So here, he has, they have 3 to 4 millimeters. Oops, I went a little further. They have the 4 millimeters of loss of attachment, which is the probe depth plus the recession, and that gives them the, it takes me to stage 2. And they also have probe depths that if I didn't see this, I would look at their probe depths. But you got to remember that if you're going to use probe depths and there's no loss of attachment, you got to verify that they're not gingivitis, because if that radiograph shows there's no bone loss, then there's probably a pseudo pocket. So you want to make sure that you look at that. And it states it here again. If no cal's noted, then use probe depths and use the radiographs to confirm. And remember to identify the worst site and greatest loss. So now we're gonna, any questions on the last section on clinical attachment loss? If not, I'm gonna go on to radiographic bone loss, and I'm gonna have to speed it up because I don't want to take up your lunchtime. So how to measure radiographic bone loss. Remember that us as dental hygienists, it's good that we understand this and know it, but I'm always gonna consult with my dentist and ask them they're gonna be the end result for me. But it's good for me to know and how to get to there, and so I can identify and consult with them on the best stage for my patient in identifying the radiographic bone loss. And when we find radiographic bone loss, remember the percentage that you come up with, because you're going to use it again later in your grading in indirect progression of loss. We're going to see it in the grading section. So we're going to go over each one of these as we to go into details. So step 1, you want to measure the CEJ 2 millimeters apical. This will give you the supracrestal tissue attachment, AKA biological width. You're going to see that it's going to give you that 2 millimeters. So then once you find that, you're going to measure the root from underneath that 2 millimeters all the way down to the apex, and you're going to get the root length. And then you're going to take it and you're going to divide it by 3, and this will give you the coronal third, middle third, and apical third. And this is how you identify that. This is another image just showing you now that once you found the coronal third, now you to find your upper 15%, which is stage 1. If you have your form in front of you, you'll see that the coronal third states on radiographic bone loss, it says 15%. So you're going to divide that by 2 to get your coronal third, 15%. And remember that stage 1 is the most difficult one to identify. So it'll take you some looking into and to ensure that it's not gingivitis, but it actually is stage 1. So this is a great, I like this slide because it shows changes in the crestal lamina dura. And so when I look at it, I see that this is the alveolar crest is pristine. I start to see some fuzziness of the crestal lamina dura. And so it starts to identify the radiographic bone loss, and it helps me with my identifying the level that they're at. If they're at the coronal third, middle third, or extended pass. So again, when I mentioned in step 1, using your probe chart, it also helps you identify furcations and mobility. And this will help you when you get to your complexities. It'll guide you and you already know where that patient is going to be. You kind of get an idea. They're going to be, if you see furcations on your page under complexities, you'll see that that falls under stage 3. If you see mobility on your complexities, you'll see that it falls under stage 4. So this is a way to think about this and help you identify. So this is some interactive. And so this is in the chat box. I would like you to identify the radiographic bone loss for A and then for B. Okay. Okay. I got one person, so yes. So A is what? It's going to be the middle third. So you see that this is a coronal 15%, the third 15 to 33, and now you have your middle third stage right here, and then the apical. So for B is going to be C, the 15 to 33%, because this is the 15%, stage 1, stage 2, and then your stage 3 and 4. And I have one more. What is the radiographic bone loss for this one? Remember your levels. Yes, it's B. It'd be stage 1. Did this help you? Any questions on this so far, on this section on radiographic bone loss? Okay. I'm going to go on. So now we're going to go into identifying tooth loss to periodontitis, and just some helpful hints. You want to determine how many teeth have been lost due to perio only. It cannot be missing due to caries, ortho extractions, or anything of this nature. And for staging purposes, tooth loss includes teeth already lost due to periodontitis, and those determined to be hopeless, and that must be extracted due to periodontitis. So you can count those as well. I'm going to go on, and we're going to go into, if anybody has any questions on this, but I'm going to go into complexities. And under your complexities, if you have your form in front of you, you'll see that the majority of these complexities fall under stage 3 and stage 4. And so we're going to be looking at those, and I'm going to give you some helpful hints on how to identify them. And it'll help you when you're doing this. You can look for any vertical bone loss greater than 3 millimeters. It will make it an automatic stage 3. Any furcation involvement of a class 2 or 3, an automatic stage 3. Any missing teeth lost due to periodontitis, if they have 4 or less, they'd be a stage 3. If there's 5 or more, a stage 4. If they have 20 remaining teeth or 10 opposing, they're going to be an automatic stage 4. And also the tooth mobility of 2 degrees or greater, they would be a stage 4. So hopefully these helpful hints will help guide you, and it'll keep you, once you're doing your perio assessment, this is where you already have an idea of what this patient's going to be. And that's a great thing. So, and also your radiographs, they identify furcations and vertical defects. And so when you see this on a patient, you're already having an idea of where you're going to go. And this is just showing you how to look for that and what you're looking for as far as vertical bone loss and perforations. And this is an example of a patient with stage 4 bite collapse, drifting or flaring teeth, and he has less than 20 remaining teeth. So now we're going to go into determining the extent. Did anybody have any questions on the last part? On the complexities and identifying them? Okay, so we're going to go on to determining the extent. And we all know how to get the extent of distribution. So when we use extent, what the AAP says is to identify the worst area. So when we do it, we have the students count the number of teeth in the mouth, times it times 0.30, and it'll give me a number. So example, if a patient has 28 teeth and I times it times 0.3, I'm going to get 8.4. So this patient, if they have over 8 teeth that I identified, I'm going to identify the worst area. If I identify a stage 3 and they have over 8 teeth with stage 3 classification, then I'm going to call them generalized. If they have less than 8 teeth of a stage 3, then I would call them localized. I'm going to identify the worst area in the mouth and the worst stage. And that's what I'm going to write my, that's how I'm going to identify if they're generalized or localized. And then remember the molar incisor, it replaces the aggressive periodontitis from the 1999 classification. So if there's no questions on the extent, we're going to move on. Please open your mic if you do, if I don't see it, but we're going to go on to practicing staging. So have your form ready on the staging. We're going to only practice identify stage, that's it. We're not going to identify extent or anything. We're just going to identify the stage with the criteria that I'm going to provide. So have your form available to help you. So this first case, this patient presents with 3 to 4 millimeters of clinical attachment loss. So you're going to identify that on your form. They have radiographic bone loss of 25%. And in between on that coronal third, you're going to see that it falls between 15 and 33. And then total tooth loss, there's no tooth loss. Probe depths, less than 5 millimeters and mostly horizontal. What stage would you put this patient in? Should have given you a little time to. Yes.
Twos.
Good job. Thank you. And they also, I think I put in that no tooth loss. There we go. Yes. So our next one, I apologize. Here we go. Our next one. Identify the stage with the information provided. So this one has a little more complexity. So you already know where it's going to guide you. And I'm going to bring up the and go ahead and put in your chat box what you're finding with all the information provided. I was looking for my pen.
A lot of 4s in the chat box.
Good job. I agree because they have this, they have bone loss extending there. They have this tooth loss, more than 5, loss due to perio. They have the stage 3 complexities. I love my artwork. They have the masticatory dysfunction. They also have the mobility. They have ridge defects. They have a lot, except they still have quite a few teeth. But I do agree that they are a stage 4. And let me find this enter. Oops, and that is correct. Did that help with all of this, the staging and grading? Did this information kind of using your form and looking as you're doing your assessments help you get to that stage and confirm it? I hope this helped. So if there isn't any question, we're going to go on to the grading section. Grading aims to indicate the rate of periodontitis progression, responsiveness to standard therapy, and the potential impact on systemic health. And I really love this part that they brought this in this grade, because it really helps us identify and educate patients on the connection of the oral health and the systemic health. So this is your grading form, and if you have it in a little sleeve, you just flip it over, double-sided. And so we're going to review the direct evidence right here, and we're going to indirect, and we'll just cover all of this here just briefly. But remember that clinicians should initially assume a grade B disease and seek specific evidence that will shift to either a grade A or a grade C. So you always want to start with a grade B. So the grade of a patient's periodontitis is based on the availability of direct or indirect evidence of disease progression and grade modifiers. The direct evidence uses radiographic bone loss of longitudinal observations of 5 years, up to 5 years. So if they haven't had any loss of any bone loss over 5 years, then you would assume they're a grade A. If you have radiographic to compare, if you have a grade B, if they have less than 2 over 5 years, then you would make them a grade B. Or a grade C of 2 millimeters or greater over 5 years, then the grade C. So the indirect evidence is based on assessments of bone loss at the worst affected tooth and the dentition, and this is where you're going to need your calculator. As a function of age, you're going to take that radiographic bone loss that you identified in the stage, and you're going to bring it over and use it in here and divide it by the patient's age to come up with a percentage. And if they fall under 0.25, they'd be a grade A. If they fall between 0.25 to 1, they'd be a grade B. And if they're 1.1 or 1.01, they would be a grade C, and so on. So this is how you would do this. And I have a little example here. So you have your calculator out, or I'll do a little interactive math here. So the radiographic bone loss on this patient is 15% and their age is 62. What grade would you provide this patient? Can't see, I need to pull up the chat. Yes.
Several A's coming into the chat box, and
That's
think we're
correct.
coming close to the hour here.
Okay.
So
let me move on then. Let me go on. So the other thing on the grading is we have grade modifiers, and these can change a patient's grade. As soon as you hear this, this is where I came with. If they're a smoker or diabetic and they're a 7.1 and they know that, then you already have an idea of what their grade will be. There'll be a grade B. If they smoke less than 9 cigarettes, then you know, or 10 cigarettes, you know they're a grade B, and so on. So let's go on to the little case study so I can get you out the door. Just a real quick recap. Always start with a grade B default. If direct evidence of progression is not available, then you'll use indirect evidence. That's where your math comes in. You always want to look at response to previous therapy and also medical history, systemic issues, and there's other risk factors that can play a part in this. Habit, periodontal pathogens, OHI, and social atmosphere. So that's something you're going to look at. So we're going to practice now. And this first patient is 30 years old and they have 15% bone loss. And they report no risk factors. So what grade do you give them? And your math. Let me go see here. Whoops, I already cheated here. I showed you. So what is the percentage that you come up with? I'm trying to figure out my little clicker here. Did all of you come out with 0.50? I can't see the chat. Let's see here. Yes. Okay. And so they fall into this area right here, the 25 to 1. and they would be a grade B. Okay, so now this patient divulges that, I'm trying to hit enter, that they're diabetic. They didn't tell you that before, and they have an A1C of 7.2. What does this change them to? I'm just gonna click on this.
A lot of great C's in the chat.
Correct. Good job. Okay, so here's our last one. This patient is 65 years old. They have radiographic bone loss of 15%, and they report no risk factors. What is your calculation on this? What are you getting? Yes. Let me hear. Enter. I'm trying to hit my enter button here. I'm trying to get it here. There it goes. 0.23, yes, and an A. So now they divulge that they smoke 9 cigarettes. Where does this put them? And hopefully you all put that down.
Yes, B.
Yes. Okay. So I hope this all helped you, this information, this little bit on finding clues, using what you found in your medical history and all that, help you find a grade and be aware of, and that's this form is wonderful. If you laminate it and you mark them, and when you get to your final grade and your final stage, it's going to help you come to that. So now I'm going to go into how you write a periodontal statement. This is your findings. So you can write it as localized, if that's what you found, the extent of them. Stage 1, grade A, periodontitis, and so on. So hopefully this helps you and guide you with identifying a staging grade. So with this new 2018 AAP classification, it provides clinician an improved way to categorize your patients, and it links a patient's oral health to their systemic health. So when talking to your patients about this classification, using a stage and a grade, grading patients may understand and accept their treatment that we are recommending for them. Therefore, we will have better outcomes. Let me see, I'm stuck here, hold on. So this classification can be complex, and sometimes it takes time to fully incorporate into patient care. I know that I started learning this in 2017, and believe me, I read on it and I practice it, and I think it's a great system. And I think that because it includes the systemic health, it's a great way. The staging, believe me, patients will understand when you give them, or your medical professionals that you correlate with will help you, will understand the patient's level of disease of their oral health and the importance of maintaining it and their systemic health. Just like a diabetic, if they're uncontrolled and their A1C is out the door and their oral health is infected, they have a correlation there. So we need to get them both under control and help them understand so they can maintain their oral health and keep it stable for the rest of their life. The new classification, like I say, it's complex, and I took time to learn it, and it just, like anything we do, practice makes perfect. And I want to
we do have a question just before we have to close out at the top of the hour. It's in the chat. Kristen Hines asked about equating rate with risk. And I wondered if you just briefly like to comment on that before we close out the session. Rate with risk.
The rate of their disease?
Kristen, would you like to clarify?
Yes, thank you. Can you hear me?
Yes, absolutely. Go right ahead.
Okay. When it's talking about the different grades, grade A is a slow rate, grade B, moderate rate. Can you make, let's say you wanted to describe a patient's risk status, perio risk status, would you say that you could, if they're a grade A, they're a low risk?
Yes. Yes, there are.
And if they're a C, it would be a high risk for
Yes.
perio. Can you make those associations? Okay.
Yes, and the association is that when they're a low risk, you want to you can maybe maintain them every 4 months instead of every 3 months, and because they're taking ownership of their oral health and their systemic issues, but say they're not as good with their OHI and their compliance. So maybe you need to bring them in every 3 months. And so that B and C, especially the C, if they have more systemic issues in that, you might want to monitor them on a more frequent base than every 4 months, because you only, on perio maintenance patients, you want to keep them every 3 months. But sometimes if they're really good, you can extend it a month out, but I wouldn't go any further, especially if they have implants like a stage 3 that we need to monitor more, just like a stage 1 and 2. Every 3 months is good. It's more falls on compliance and helping the patient understand the importance of their oral health and coming in for their recare appointments so that we can help them keep their teeth for the rest of their life. Did I answer?
Thank you. Yes, appreciate that.
Thank you. We are coming to the top of the hour, so let's.
There was one more question in the chat earlier on from Dr. Shelkey, and he was asking about whether the Cairo classification is still based on mucogingival junction as Miller classification.
Yes, and it goes into like state that the RT1 is more like toothbrush abrasion, and it's a little bit of the class 1 and maybe class 2 that they put in there, but that's they're still using them, but they'll show it that how they identify it, and then your class RT2 gets more, I guess, into your class 3, and then the RT3, class 4. Yes.
Thank you.
Thank you so much. Were there any other questions? Sorry, Rosalie.
No, thank you, Maria.
Hello, can you hear me?
Yes, absolutely. Go right
ahead. This is Dr. Murphy.
Hi, Dr. Murphy.
And I wanted to thank you for your presentation today.
Oh,
I think we all kind of try to simplify our understanding, although perio has been around for a long time, trying to simplify and classify an approach to explanation and treatment. I think this newer classification system, it's got some complexities, as you said, but I think it's a lot easier with your guidelines to understand. So I thank you for that, and I thank you for your reference to Carrillo and R2D2 as a point of reference to remember.
Yes.
I wonder if you might just elaborate on a situation that sometimes that I run across that is sometimes different from the ongoing stage 4 issues, but where an individual over the age of 60 appears to be negative on systemic background problems, all of their A1Cs, all appears to be normal, all the reports are normal. The tissues appear pink and viable and attached. However, and no probing, minimal probing depth, less than no greater than 3.
Yes.
But there is obvious recession. There's obvious recession around the teeth, although no bleeding. Tissues are tight, and the question is, and commonly there's traumatic occlusion problem, but there's no active bleeding, doesn't appear to be an active pathology going on, yet physically you can see that there is recession going on and the patient is concerned. What would be your approach to that?
I would first look at their home care habits. What type of toothbrush are they using? Because you're saying they're having continued loss of attachment?
They seem to be, the attachment's not so much a problem. The attachment seems to be following the recession. But the recession is, seems to be, have progress to it. No, there's no
Okay.
mobility, but
No
you see
mobility,
they're
but just
finding that-
maybe it's their toothbrush habits, and maybe they're more aggressive. I don't, thinking clenching. I would have to look into it a little more just to identify that. Have they ever had a, so are you asking if, just to find out why they're having this, but not how to classify it, right?
Well, how I think it almost appears when you look at it, you want to begin classifying a little bit greater than what you're finding directly because of this recession.
Yeah.
But the
So
treatment.
are you thinking that
approach,
are you going to that healthy but reduced periodontium? Is that what you're asking about, or do
that's it. They're the words right there. That's
Yeah.
exactly,
Yeah.
that's perfect.
That's what I'm thinking, because if you're saying that they don't have any bleeding and they're minimal, they probably, and they haven't had any past history of non-surgical periodontal therapy?
No history of non-surgical perio.
That's a good one, because I mean, I'm thinking of the gingivitis, plaque-induced gingivitis and the non-plaque-induced gingivitis, and we got to look at their systemic issues and what are going on with them to see if that's the cause of their attachment loss.
Do you think you have a recommendation on the toothbrushes if you were going to recommend to a person like this?
I would always
over,
soft, not medium, not hard, always soft, because if they really need to feel it, ask them to brush without any toothpaste first, so they can feel the bristles where they're hitting their gum tissues. At the same time, they're massaging them, and they'll feel the bristles getting down into the sulcus a little. And then when they're all done, they can go back in with the toothpaste and rebrush. They've not only brushed longer, but they've touched every surface. So.
Well, what about the ultrasonic toothbrushes? Better, worse in situations like this? Or
Well, I'm glad that they have that sensor on them when they're being too aggressive, because it's going to be going beeping all the way. Beep, beep, beep.
Well, thank you very much. And thank you for your reference to the diabetic situation, A1C, because that contributes a lot to our patient profile that we see here. And with that, I'll sign off and thank you so much.
I appreciate your comments and your questions.
I will echo that and thank everybody for joining us in this wonderfully interactive session. Have a lovely day, stay safe and warm. We hope to see you in the next Dent Echo. Thank you, everybody.
Thank you.